Welcome to Progenesis Academy webinar series. We have just launched a new special session honoring the IVF pioneers. This event will take place once a month. It's an interview format during which we will invite an expert in the field of IVF, whether genetics or reproductive medicine or embryology or other fields. And we are choosing guests that are that have impacted the IVF field in a great way. Today, I have the pleasure to welcome Dr. Santiago Munné, our special guest for today.
Thank you, Javier.
Santiago, welcome. Welcome to the webinar. I'm going to make a quick introduction. Obviously, it's very difficult to introduce Santi in a few words, but I will make my best effort to make that happen in a short statement. So Dr. Munné has a PhD in genetics from the Pittsburgh University. In 1993, he was the first to develop pre-implantation genetic testing, PGT. Back then, we used to call it PGS. And as a result, he received a SART award in 1994 and 95. He was also the first scientist to develop translocation tests and received a SART prize for it in 1996. He was the first to demonstrate the effectiveness of PGT, reducing miscarriage and increasing implantation rates. Also received a SART award in 98. And to look at the career of Santi, he has published hundreds of papers of publications in the field of reproductive genetics. He founded Reprogenetics, a first company to commercialize PGT in IVF. He also founded other companies, including Recombine, Made Answers, Overture, and Homo Health Venture. Santiago, welcome.
Thank you very much, Nabil. It's a pleasure to be here.
Awesome. Now I think we can take the flyer out of the, so that we have a close look. So I have a few questions. Obviously, the conversation is going to start with PGT, since we are in the PGT field, the two of us. So when you look at PGT back then, when you first developed the first test, and PGT today, what are the main changes in the evolution of PGT that have marked the field of IVF?
At the time when we started, we were only counting 3 chromosomes, 3 to 5. So 5 spots in the whole genome. And now we're able to do whole genome sequencing, so reading every single letter of the genome. So as you can imagine, we went from really the most early stage to complete genome sequencing right now. At the beginning, as I said, we were using just 3 fish probes. So these were little pieces of DNA with a fluorescent tag that you hybridize to a fixed cell. You needed to know how to fix the cells well. That here already was a huge difference between centers, and so some people couldn't make it work. And then a 4th color appeared, and which gave us the possibility to do combinations of colors. So first we just had green and red. So if you combine them, you have yellow. So you could, for instance, we were using a probe in green for chromosome X, a probe in red for chromosome Y, and then you mix them, well, green and red, and it was, we tag chromosome 18 in 2 colors. So you have 3 colors basically. Once the blue appeared, then we had all these other combinations, and at the end we were able to, I think, do 9 chromosomes in different races of combinations. That was at the early stages. Then the technology changed to arrays. That also brought quite a bit of change to the field because new companies from left field appear, new players. So it was a big change in technology at the time. And then whole genome sequencing or next-gen sequencing appeared, and then we were able to analyze all the chromosomes. And now, in the last few years, what happened is that we're combining or started to combine sequencing with SNPs, so you could do at the same time analyze any type of PGT, PGTA, PGT-SR, PGT for monogenics. But the next step, and this is happening basically this year, is that now we are offering whole genome sequencing in order to detect not only those abnormalities that are carrier that are inherited from the parents or are chromosome abnormalities, but also will be able to detect de novo mutations. De novo mutations are actually more common than inherited mutations, and they accumulate with advanced paternal age. They accumulate in the gametes. So even if we test the parents with carrier screening, we wouldn't be able to know if they carry any of these abnormalities. Therefore, by using this new technology, we'll be able now to detect absolutely any type of genetic abnormality. And this is going to be basically a collaboration between Gene Embryonics and Progenesis. Also, there are a couple more other companies offering it, I think. And so, yeah, as you could see, we started with just testing 3 points in the genome to detect now every single SNP,
Awesome.
every single letter.
Yeah, and I'm going to come to the whole genome sequencing in a minute. When you look at all these technologies that have been used, from FISH to microarray and NGS, did it improve clinical outcome?
Definitely. There was a big change from the 8 probes to whole genome, from the 8 probes to the whole chromosome spectrum. That happened in around 2003 with arrays, with SNP arrays, and then we were able to analyze all the chromosomes, and then it's when basically good results. This was published by Richard Scott and others. We were able to really convince more people that the technique was working before, because it was very finicky, depending on how you did the fixation, etc. The results were very difficult to be exported to other labs. And a lot of the easiest thing when you cannot copy something or when you cannot replicate it is say that it doesn't work, right? So there was a lot of skeptics at the time. With the new technologies, which were manufactured by Illumina or other companies, then it was much easier to demonstrate that it worked. And now, right now, we have in the US over 50% of all the babies born from IVF do have PGT. So it's almost as many PGTs as ICSIs.
Yeah, but were you saying that better technology is translating to better clinical outcome?
Yeah, definitely.
Yeah. Okay, very good. The adoption of PGT has increased in the US, but not necessarily in other countries. You look at the adoption of PGT in Europe and in India and in some of the Latin American countries, and it's still very low. What do you think that is attributed to?
So the major difference between Europe and the US is that in the US, well, you have 2 things in the US. One, usually it's not covered IVF by insurance. And second, we have SART that you report, every center reports their results, so people could check which centers are better. And that created, a lot of competition to get better clinical results. And also because you're not paid by the state that pays by the number of cycles you do, you're paid by patients that want results. That I think has made that the US has better results, adopts new technologies much faster. In Europe, especially Northern Europe, where it's paid but badly paid, you have to do many cycles in order to get the pregnancy, much more than in the US. But then they have to cut all the things. So the incentive is not in getting people pregnant. The incentive is in doing more cycles. Meanwhile, here the incentive is to getting a baby with the fewer cycles possible because the patient cannot pay as much.
Okay, and do you think there is any other components like cultural components? Because I know that in the European society, maybe they're more conservative.
Yeah, that's true. You have, let's say, Germany, that for historical reasons, they forbid PGT, they forbid the selection of embryos, and that also happens in a couple of other countries. But then you have also, for instance, in France, it's very socialized medicine. You have only 3 licenses to do PGT and only for monogenic diseases by law. So there are some impediments to the spread of it. The country, Spain, has quite a bit of adoption. Turkey has quite a bit of adoption. Italy had quite a bit of adoption. And it's because they were not as subsidized as Northern European countries.
Very good, very good. So let's talk now about a topic that has been of interest for a long time, and I don't think has been addressed properly, which is mosaicism. Your view on mosaicism, has it changed over time?
Yeah, it has evolved quite a bit, up and down and up and down. So when we were doing fish, when we were using probes and we were analyzing every single cell independently, we could see clearly that mosaicism was there. And it was very common in day 3 embryos. At the time we were biopsying day 3 embryos, we couldn't yet culture to blastocyst stage. And at that stage, there is much more mosaicism than on day 5. And you could see because you were looking at each cell that, let's say, one cell was missing a chromosome and the other had an extra chromosome. Or you could see that it has lost one chromosome and then you see a micronucleus with that chromosome. So definitely you could document very well that it was mosaicism. Once we moved to analyzing a bunch of cells in the same tube with next-gen sequencing or other methods, then we get an average of those cells. So all these nuance gets lost. And so at the beginning, when we were doing the first studies when we went from arrays to next-gen sequencing, the resolution increased and we were able to see in between, we were able to see intermediate results. We attributed it to mosaicism, which some could be noise, but you lose a lot of this nuance. At the beginning, since we didn't know what was the effect of transferring these embryos, we were more cautious. We said not to transfer them at the beginning. Then maybe we keep changing. After they were the first babies, we said, okay, maybe we could transfer them. So they are not fully abnormal because some come in babies, but the retrospective data that we had was that they implanted less and they miscarry more. So we said there are 3 groups, normal embryos, mosaics, and abnormal, never transfer abnormals, but mosaics have to be treated as an intermediate group. Now, with prospective studies, what we've seen is that the embryo, it has less than 50% abnormal cells. Basically, the normal cells take over. They divide faster than the abnormal ones. And at the end, that embryo can take over. And mostly well, mostly, the studies show now that those implant equally well than normal embryos. Therefore, we shouldn't classify them as mosaics because, or we shouldn't say it in the report at least, because that creates anxiety in the patient. So most centers, I think now, basically they're saying below 40%, 50%, depends on the center, we'll call it normal, and above, still those mosaics has, or still, because we don't have prospective data yet on mosaics over 50%. So right now we still need to treat them as a separate group with a higher risk of miscarriage and less implantation than abnormal embryos, and some may be abnormal, right? But all the transfers of mosaic embryos that have been done, now we get the same amount of congenital abnormalities, we say the same amount of babies that are mosaic or with a chromosomal abnormality than euploid embryos. So there is very little risk of transferring them.
Very good. The other question I had is on the non-invasive PGT. The first attempt to do non-invasive was probably in the 2017 or so, and we've seen many labs publish papers on correlations between non-invasive and biopsy. And what is your assessment of that? Is this a viable test? Do you think could this be an alternative to biopsy procedures?
Yeah, so far most of the papers published, I would say 99% of them, they've done embryo biopsy and then they tested the spen media and then compared it to see what's the correlation. First, usually you get 80-90% of samples only informative, so 10-20% are not informative. And then the correlation on average, there are some very good centers that have 100% correlation, but usually those are papers that are single center reports, so the center has good quality controls to minimize maternal contamination. But when you have a reference center, you send samples from many IVF centers to one PGT lab. For instance, is the data from iGenomics. You have 70% more or less correlation, which if you add it with 10-20% no results, gives you basically less than 70% or 70% more or less correlation and information. So the test is not there yet. Also, we don't know if we are saying that it's less invasive and therefore we should have better results. But there have been very few studies that have not done biopsy. So we still are missing data to show us that by doing non-invasive selection of embryos, we could improve results above biopsy.
Very good. Any other non-invasive or any other new technology could be could have a potential to change the PGT direction, or do you think it's just a matter of increasing accuracy and there's no other breakthrough technology that would appear in the future? What is your read of the future?
No, we have three major ones. So AI, that is on average also you have about 70% area under the curve resolution in selecting euploid embryos or implanting embryos. We have non-invasive PGT that we already talked about it. And the third is metabolomics. Progenesis, Overture, and other companies are following this path. And the interesting thing is that the results there are that if you test euploid embryos with metabolomics, you know that the best results in PGT, you get, with invasive PGT, you get about 70% implantation. But with metabolomics on euploid embryos, you can identify 30% of embryos that never implant, and that's 30% missing, right? So by combining the two, we could really improve, I think, results. So those techniques are still in development or in validation, but I think that could be very interesting.
So you see a fusion, some sort of fusion between PGT, non-invasive,
Or yeah, or the all the non-invasive combined could give us probably a better result than the invasive.
Very good. So now outside of PGT, because the PGT obviously is the main focus, but outside of PGT, there have been a lot of changes in IVF science. One of them is, the ICSI, the changes in ICSI and vitrification. I think they made a big impact in clinical outcome, but also IVF lab automation. And you were part of this history of trying to automate the IVF lab. Tell us a little bit about, in a snapshot, what that experience looks like and what is the hope for automation in IVF.
Yeah, this started a long time ago, really, also at Cornell. So in Cornell, we developed the first PGTA, but also Jack Cohen developed most of the micromodulation techniques that we're still using. And also we adopted Gianpiero Palermo when he left Holland to work on ICSI. So most of these techniques were developed at Cornell. And from there, I always got also the let's say the interest in that field. And one of the things that I realized when I went to work with Martin Barsowski in this other company, Overture, was that, or from the experience in PGT that I had, as I said before, if people cannot replicate well your technique because they don't do it correctly, they don't do it as it should, even if you publish it, they will say it doesn't work. So it takes a long time for a technology to be adopted. And then you have lots of variability. We published that, for instance, in egg donors, that they should be more or less give you the same results in every lab. We had huge difference from 30% normal embryos to 70% normal embryos. So huge difference depending on who does the technique. So obviously, with Martin Barsowski, we realized that we had to do something about it, and automation was the logical thing. So we started working on two projects. One to automate vitrification of eggs, which is, I think, one of the techniques, vitrification of eggs, that really will change as much embryology as ICSI or PGT. And the other was to automate also ICSI. And these are two very different concepts if you think about it. So ICSI, automating ICSI is part of the standard IVF lab, so this will happen for sure, and it's needed for a standard IVF laboratory. But freezing eggs, if you simplify it a lot, you could do it then in every OBGYN office, and then you could do fertility preservation and really widespread, which is really what we need, because people are replacing later and later. Most societies right now developing and develop, the population is crashing. So those are two techniques, I think, the most important ones that need to be automated, and they're being automated.
Yeah. So these automation efforts, which is one of them is the ICSI automation, and the new birth, the new first ever baby with automated ICSI, which obviously was the prize that you received, the Robert Edwards Prize. Tell us about this experience. How were you contacted by them? How did it translate into this, and what does this award represent for you?
Well, no, I wasn't contacted by them. So basically, this was my idea, and of Nuno um, Nuno Borges at his company, Embryo. Sorry, I forgot his company now. Um, anyway, basically, the investors at Overture that we funded with Martin Varsavsky, they were really focused on egg vitrification. They are still are, and basically right now they are we are, because I'm still forming part of the company. They are about to do trials for FDA. So this will be probably the machine could be available at the end of the year. But also I wanted to automate ICSI because for obvious reasons. So we dedicated a small budget to basically develop ICSI with a small team of people within the big company. And I subcontracted the people at Embry Tools in Barcelona, Nuno Borges and Gloria Calderon, to help us develop this part of the process. And it was, the people that you see in the paper basically were all involved in this project. We did it very agile because we had a very little budget within the company. The goal of the company, the laser focus goal was to automate vitrification, but with a lot of insights from very good embryologists like them. And then also we were able to do these first babies at New Hope in Zhangjiang, also a real innovator in the field of IVF. So combining these great people, we were able to do it with a very low budget and very quick.
Yeah, and I'm sure the automation, this is just the beginning, and there's a bigger scope of automation in IVF space. Is there any concern that automation may at some point replace the embryologist or the some of those basic functions of MDs? Do you see this as a potential, threat, or what is your read of that?
It's a positive and a negative. So it's positive because I think automation will give us platforms where to innovate more. As I said before, like my experience in PhD, it took 20 years to convince like more than 50% of patients that it's a good thing. Meanwhile, if we had a platform, let's say, that could give us exactly the same biopsies in every center, it will be much easier to keep innovating on top of that. So platforms will that basically give you a baseline of results, allow you to innovate on top of it. For instance, the EmbryoScope. That's a great platform because on top of it now we have been able to, with AI, create new technology. But if you then had the same platform and the same results in every center, the same pictures and so on, you wouldn't be able to do all that. So these platforms, I think they will be very good for creating more innovation. Obviously, they are going to make disappear some technician jobs that basically are pipetting and doing tedious work, but there's a lot of people doing that job and they are well-paid jobs. So we'll be able to, let's say, as an embryologist, you'll be able to do science again, but I think we won't need so many of them. So definitely it's going to impact the field, the same as AI. It's going to impact very good jobs right now in the middle upper class. So this is inevitable, I think. I was just reading this book, Progress and Power. I recommend it, although it's a little bit woke. but basically it depends on how you use the technology. If you just use it to cut cost, or you use it to create new skills for the embryologist, then it could be a good thing. If you just use it to cut costs, then you are going to innovate in a different way, and it's going to be basically not as good for the embryologist.
Very good. Well, we're going to put a poll for the audience to answer some questions while we are continuing this exciting conversation with Dr. Munné. Lindsay or Thomas, if you can put the poll on the poll is about mosaicism. What's your rate of mosaicism? And some questions about pregnancy rates in your organization. How do you currently handle mosaic results? And do you test for 1PN or 3PN embryos for triploidy and haploidy? And in the meantime, while waiting for this poll, which will end in 4 minutes, so please proceed with those answers, and we're going to continue our conversation with Dr. Munné. So I'm going to transition a little bit from the science to more of a read of the industry. And when we say industry, I'm referring to the genetic testing space, but also the IVF space. So if you look at the last 2 years or so, the genetic space, particularly carrier screening and NIPT, have seen a lot of consolidations. And so we've seen companies like Progenity and Council, Semaphore, Invitae, many others have changed direction. Some of them went out completely. Some of them were acquired, things like that. How do you attribute this instability in genetic space in IVF?
Well, I think this has been a lot of, let's say that the technology has changed in a way that right now it's very cheap to do this test. So there are a lot of companies doing exactly the same. And especially in carrier screening, the problem more than the technology is the insurance. So if you are not enabled with one of these insurance, it's going to be very difficult to get paid. It's very unstable in that way. So it's also difficult to disrupt it because unless you have these contracts, it's difficult to. For instance, when we're at at Progenesis, which we founded with Alex Vicignano to do carrier screening, it was already difficult to get these contracts with insurance. Then when Overture bought us, with Cooper bought us, they had no clue that they needed insurance contracts, and at the end they had to basically they closed that line of business.
And we see the same thing. Those challenges and those consolidations are also happening in the genetics, in the PGT space as well. What is going back to the reproductive genetics? How does the picture look like, 5 years, 10 years? Do you think there are going to be more consolidations? We're going to end up with having one or two main providers, or what's the future look like in your opinion?
Definitely, there's a lot of consolidation. There is some vertical consolidation between providers of everything, and now adding genetics to it. But also there is, with new technologies, these big companies, usually they don't innovate very fast. So there's always a room for new companies and new innovations to appear.
Yeah, exactly. A similar consolidation is now being seen for a few years already in the IVF. IVF clinics are reorganized into networks. In the US, I don't know if it's more than 40% or 50% of the clinics are already organized in networks. I may be wrong about the exact number, but it's certainly a big number. And we have seen this surfacing in Brazil and also in India. There are a lot of consolidations in IVF space. When I was talking to one of my friends, he said that there are other medical fields that have gone through similar trend. And so can we assume that eventually in the IVF, there will be only maybe a couple of players that are dominating the markets in the next few years? Is that a fair assumption?
That's how these companies think. And yes, the trend is in that direction. Obviously, the problem is that at least for the majority of these networks, it's funded by PE, that they want to flip it to another buyer in a couple of years. So the goal is usually not to stay in the market, but just resell it, and therefore they have to cut costs left and right. So it's concerning that results may start going down. Definitely research and development, it's being cut in some of these networks. That may give room for new players to appear if results start going down, just because they need to cut costs to resell it.
Yeah. I have seen cases where network have maintained this personalized medicine as well. So we can't obviously generalize. There are networks that have done really good work in improving quality.
Mm-hmm.
Yeah.
Because some already have gone through several rounds of selling to each other, for instance. Yeah, in Europe it's more common.
It's more common. Awesome. Let's look at the poll results. I'm going to read this. When we ask what is your rate of mosaicism, the majority did not answer this question, but we have 5% and 8%. And then what is your pregnancy rate? And we have only few answers. It looks like the majority of the attendees did not answer the poll. Thomas, if you can relaunch the poll one more time, maybe we can capture more. And if we see that the numbers are low, then we probably just communicate this information later. Can we relaunch the poll one more time?
Yeah, Lindsay, would you mind putting that poll back up one more time?
Maybe the attendees did not have enough time to answer.
I'm working on it. I can create another poll and share it in a second.
Yeah, we have plenty of time. Okay, so Santi, I have interest in your career as a scientist, but also as an entrepreneur. You are the perfect example of someone who excels at science that also has a very good sense of business. And you have done this at Reprogenetics, the first company to launch a commercial PGT, have done hundreds of thousands tests, has operated in multiple countries. Really, our very first example of a PGT company that has grown worldwide. How did you manage this transition from being, a scientist, someone who invented the PGT, workflow, to having to run a company with this complexity? Did it require you to go through adjustments and things like that?
I always said I'm an accidental entrepreneur. It just happened. We developed the test. People start asking for the test and said, "Oh, we have a company here," and that's how all started. We didn't have investors. It was all organic at the beginning. not at the beginning and at the end. So we never had investors. I think it's very similar to what you have, Nabil. And, and no, it didn't require adjustments I think, in the way of thinking, because at least at Reprogenetics, we were selling the product based on the science. So people really believe in the science. We publish a lot. That was our only PR, basically. So it was still a very science-oriented company.
Awesome. So certainly it is a very big task to run a multi-international company with multiple branches, and I am going through a very similar experience, having to run Progenesis in India, in Brazil, now in Turkey, and the teams are growing in different countries. So definitely is a big challenge. How do you balance these level of commitments? Now, obviously, you're not involved in Reprogenetics, and you have, founded other companies, and your level of involvements in decisions is pretty, strong. How do you balance that with your personal life?
It's difficult. At least I have the luck that my two daughters are now older. Both of them are artists, and it's not because they escape science escapes a generation. My father was an artist, so I escaped one generation of artists, and they are very well educated, and I'm very proud of them. But yes, I'm traveling a lot. I'm never more than 1 week, I think, in the same place, and it takes a toll on your relationships.
Yeah, absolutely. So, with your level of experience, you're obviously, the pioneer. To me, you're the pioneer in reproductive genetics, and any organization would have loved to have you right on board. You've decided to join Progenesis as a scientific director. Why is that choice?
Well, to me it felt like working again in reprogenetics. Basically, science oriented, funded. There are no VCs. It gave me the same feel. I definitely didn't want to work in a huge corporation where you have little say. Oh yeah.
Yeah, awesome. Very good. So I think our time is getting close to the end of this interview. It has been a true pleasure to have Dr. Munné as a special guest, my first guest in this webinar series. The next speaker is going to be Professor Jamie Griffo, professor and program director at NYU program. That will be next month. This webinar special session is separate from our bi-weekly webinars. It's really meant to connect on a personal level with our, people who have really impacted our field, and to know them on a personal level, but also to go through their career path, and hopefully to see this as an inspiration for all of us. We have gotten an update on the poll, slightly more numbers. We're gonna probably attempt to send this poll via email to try to get more answers, because it's really important for us to know, what your experience is, and because that's part of the conversation. If you're having high metastasis rates, why is that, and what is your experience choosing certain, making certain decisions? But just looking at this very small sample, as far as how do you handle mosaicism rate, it looks like majority are transferring mosaic results, whether with genetic counseling or without genetic counseling. And when we ask, do you test for triploidy and haploidy? From the one who answered the poll, and they don't test yet. And I have to let you guys know that there is a test for it, whether at Progenesis or somewhere else, but you can test for triploidy. In our experience, you can increase the usability of embryos by testing with SNPs. About 40% of 3PN are euploid, 60% triploid, and 30% of the 1PN are haploid, and 70% are diploid. So you don't want to discard them. You probably would be better off testing them. With this, we are coming to the end of this special session. I would like to thank again Dr. Munné for his time, and I will see you next month.